This is Module 6 of the Experimental Studies Week for Public Health 502. We're going to focus on the analysis that we do at the end of our experimental study, or our randomized controlled trial. Learning objectives for this module want you to understand how we analyze experimental studies, including an assessment of randomization, and talk about some of the measures we use, like risk ratios, efficacy, and number needed to treat, and then talk about the all-important intent to treat analysis and why we need to keep everybody in the treatment group they started out in. So one of the first things you want to do at the end of your trial before you analyze your results is to make sure that your randomization process was successful. Sometimes that's called the balance analysis, and you want to see that all the observable characteristics that we were able to collect, like gender and age and race ethnicity and disease comorbidity and things like that, are balanced between your treatment and your control group or across your multiple intervention groups. If you find out that there are differences, and that certainly happens, you just want to make sure you control for them in your analysis, and you can do that in a regression framework, for example. If you take the Banerjee and Duflo paper on immunizations and the incentives, Table 1 is their baseline analysis, and if you look across control group treatment A and treatment B, you can see by and large the groups look pretty comparable across the dozen or so measures that they look at. So if we look at the mean number of rooms in the house, in the control group it was 2.0, in the treatment A group it was 2.1, and in treatment B it was 1.9. And they have confidence intervals there, so you can see if those are significant. So that's an important component right up front. We can use lots of different measures of association or outcome to test if the treatment and control groups are different. Some of them you're familiar with already. You can use a risk ratio, either an incident rate ratio or a cumulative incidence ratio. And in all of those, we're asking basically the same questions we've asked in other study designs. Is the risk of the disease or whatever endpoint we're measuring higher or lower in the treated versus the control group? There's also a measure called efficacy. And if you see efficacy, it's just the difference in the rate between the control and treatment over the original control rate. So it's sort of a percent change in the outcome that we're interested in. There's also an analysis called number needed to treat. We see it abbreviated as NNT. Gordis mentions it. And we calculate it as 1 over the difference between the treatment and control. And it's a very intuitive result. It tells us how many patients would we need to treat with our new treatment to prevent one adverse outcome. So that's a nice sort of public health, population health measure where you can say, okay, this treatment worked in my randomized control trial, but I would have to treat so many people to get one additional adverse outcome prevented that it's not feasible or it's not attractive. Number needed to treat comes up, or at least it came up recently when the U.S. Preventive Services Task Force came out with its new guidelines for mammography and determined that so many women would need mammography between ages 40 and 50 in order to prevent one breast cancer death that it really didn't make any sense. And interestingly, from sort of a media and popular imagination standpoint, it turns out that American women are very comfortable and happy to get as many mammograms as we tell them to in order to think that they're preventing even one breast cancer death. So even though number needed to treat is a good metric for sort of cost effectiveness, it's not always a vivid or compelling measure with people. Here's one example of looking at aspirin versus placebo and looking at two different sets of endpoints. One is myocardial infarction, otherwise known as heart attack, and one is stroke. And what's nice about this analysis is they've actually stratified their endpoints into fatal and non-fatal MIs and fatal and non-fatal strokes. And the risk ratio over here is telling you how much better or worse aspirin has done versus the placebo. So it turns out aspirin has a very good risk ratio in terms of reducing fatal myocardial infarctions. The risk ratio is 0.25. However, relative to placebo, it actually increases the risk of a fatal stroke by about a factor of 3. So this gives you a patient, a provider, an aspirin maker, a new drug developer, really nice information about the relative risk or the risk ratio for this treatment, aspirin, for 2 different endpoints. It allows you to kind of make trade-offs. Am I more worried about MI, or am I more worried about stroke? And how do I make a decision accordingly? Now I just want to talk about intent to treat. It came up in the Duflo paper. It came up a bit in Gordis. So we have to worry about several sources of bias in our experimental studies. Some of them we talked about before in the Module 5 on running a study. One is non-compliance. We may assign people to treatment who just don't do the treatment. Another is crossovers. People who are assigned to the control group may end up getting our treatment for whatever reason. And of course, loss to follow-up. And loss to follow-up is generally okay. We just don't want it to be differential. We don't want more loss to follow-up in one group than another. But all of those happen. And if we end up analyzing our data just on who actually got the treatment and who actually got the controls, our results are going to be biased. And to avoid the bias, we do something called intent to treat, meaning we put everybody we intended to get the treatment in the treatment group, regardless of whether they got the treatment or not, and we put everybody that we intended to be in the control group, again, regardless of whether or not they got treatment. And that just keeps our results unbiased and gives us a good sense of, if we were to implement this treatment in the population more broadly, where we would see noncompliance and crossovers and loss to follow-up, what kind of population level effect might we see? So why do we have to do intent to treat? And people, analysts are sticklers about doing intent to treat for good reason. So what happens if we ignore it? Well, we're basically not in a randomized study anymore. We're basically in an observational study, which is fine, but we need to do our analyses accordingly, and we need to account for all those confounding factors that may have driven loss to follow-up or crossover or compliance. So just remember, if you fail to do intent to treat, you're basically back in an observational rather than an experimental framework. The nice thing about intent to treat is you're acknowledging that what you're randomizing is sort of the offering of the treatment, which is how it works in real life. If we've got a new drug and we're a clinician, we sit down with the patient and say, "Hi, I got this new drug." And whether they take it up or not is up to them. And our intent to treat analysis acknowledges that. And again, making a very useful sort of yardstick for a population health perspective. Now, it gives us a conservative estimate of the true effect of the treatment. So it's an unbiased assessment of the population health effect, but we've probably usually underestimated, depending on what kind of biases we might have experienced. It's a conservative estimate of the true individual effect of treatment. But sort of the scientific community has decided that we're better off with a conservative estimate that isn't biased, and the intent to treat has become the standard for evaluations of experimental trials.